Hi guys, next I'm gonna teach you an update with respect to infective endocarditis, and this came actually in the middle of 2023, but our examiner bodies were quick to spot it and they asked it immediately in the subsequent INISET exam and then even in the FMG exam. So irrespective of whichever exam you wanna be sitting for, I would like you to listen to this update very carefully. This update would be called as ISCVID, that would be International Society for Cardiovascular Infectious Disease Update. I repeat that again, IS is International Society for Cardiovascular Infectious Disease. This is an update that was published in the middle of 2023 and is not given in the 21st edition of Harrison. At this junction, the query in your mind would be that should we answer according to Harrison as you always tell us to do, or should you answer or should we answer on the basis of update? Well, because in the exam they mentioned updated latest, the word was given 2023 updated guidelines, and therefore, and which is correct about it, and obviously INISET it's going to be multiple correct options. So because they're mentioning the word updated and they're mentioning even the body as well, that is International Society for Cardiovascular Infectious Diseases, so this data is the one which is to be followed. You see, the original Duke's criteria were passed way back in 1994, and then there was an update in year 2000. So from year 2000 to 2023, well, in all textbooks all over the world, they were doing Control C, Control V, that is copy pasting the same data in the subsequent edition of the textbook. It was all about positive blood culture and positivity with respect to demonstration of bacteria or demonstration of vegetations on the surface of the heart valve utilizing an echo. So there was really not much progress going on with respect to increasing the diagnostic yield. So after a huge gap of 2 decades, the main body, the authority decided that okay, we need to wake up and we need to use more technology to increase our diagnostic yield with respect to infective endocarditis. And therefore, I'm going to teach you subsequently these updated major criteria as well as minor criteria. The major ones, the broad category, I'm going to use a mnemonic by the name of SIM. And at this junction, before I write them down, I also want to tell you that there is no change in the algorithm. You see, algorithm for Duke's criteria still the same. You need modified Duke's criteria still the same. 2 major criteria. Suppose only one is major criteria is present, then you need at least 3 minor criteria. And suppose if none of these major criteria that I'm going to tell you are going to be present, then you need at least 5 minor criteria. So the algorithm for modified Duke's criteria remains the same. It is only that additional information has been added to improve our diagnostic accuracy. Now let's focus on the first one, which is a new add-on data that they mentioned, that is surgical criteria. You would have never read about this, prior from year 2000 to year 2023. Anybody who has been a MBBS graduate has read about imaging criteria and microbiological criteria, but has never read about what you are reading at the moment, that is surgical criteria. And surgical major criteria simply means that the cardiothoracic surgeon at the time of surgery would be seeing the valve in real time. So direct inspection of the heart valve. You see, at the time of the surgery, the cardiothoracic surgeon can inspect the heart valve and he can see evidence of damage. The damage could be in the form of perforation, it could be a valve abscess, it could be a possible fistula. So any kind of damage, or even if you are evaluating the patient maybe after years because you gave antibiotics and the person did recover luckily, but at the same time there would be scarring present with respect to the valve, and that scarring can be visualized. So direct inspection of the heart valve at the time of cardiac surgery by a cardiothoracic surgeon is now taken to be a major criteria for diagnosis, even if the remaining aspect that I'm going to teach you, like the imaging criteria, are turning out to be negative, or even the microbiological criteria negative, because it has been years altogether, the patient has recovered. So now, there would be no positive blood culture. There would be no acute onset damage that would be visualized, but that cardiothoracic surgeon has seen the damage, so that's alone sufficient for diagnosis of this condition, and this was never previously mentioned in the textbooks. From the imaging perspective, echocardiography is good enough. We can do a transthoracic echocardiography, we can do a transesophageal echocardiography. So if they simply ask you, what is the first imaging modality for diagnosis of infective endocarditis, your answer is echocardiography. It has good enough sensitivity. Then why the need of more investigations? Because echo is very, very good to pick up these vegetations on the heart valves, but it is not able to evaluate the paravalvular areas well. The area surrounding the heart valve is not scanned well. So he says, use technology. You can be using cardiac CT and you can be scanning the paravalvular areas. Or instead of a cardiac CT, he says, if the facilities permit, obviously India is not a very well-off country, and I mean a lot of people may not be having resources to be able to afford a PET CT, but he says if it is available and if PET CT shows evidence of increased activity with respect to the valve or the area surrounding the valve, that is sufficient for diagnosis. Between all the three investigations, it is or, and or. It is echo or a cardiac CT or a PET CT. He says whichever is available, and if you can combine the two, you will increase your diagnostic yield. Now let's focus on the microbiological criteria. Microbiological criteria have always been with respect to a blood culture. But suppose blood culture is not turning out to be positive, reasons can be manifold for that. Person has taken antibiotics before he came to the hospital, the blood culture will not turn positive. Or for that matter of fact, the organism may not be a very common one. You see, Staph aureus, Streptococcus viridans are the common organism, the typical organisms. But sometimes the infection could be caused by a atypical organism also, or a non-typical organism like, Bartonella or Coxiella burnetii or Tropherma vipili. Remember that organism that causes Whipple's disease and malabsorption syndrome, Tropherma vipili? So if it's a non-typical organism, then he says you can use PCR. PCR is good enough to pick up any bacteria, or we can be using nucleic acid amplification technology. So instead of writing nucleic acid amplification, he might just use a short form. He might write amplicon, or he might mention metagenomic sequencing. So my point is that even if you are having a very skilled microbiologist and he's able to pick up those organisms, but then these techniques are much more superior and the turnaround time will also be lesser, and as a result of it, apart from blood culture, it is PCR or amplicon or metagenomic sequencing, whichever facility is available, would be added up so that we can increase our diagnostic yield, we can pick up a diagnosis relatively early. And once I've given you a heads up with respect to SIM, now we'll focus on individual data. And out of the three, the one that is most likely to be asked and has been asked again both in INISAT and the FMG exam is with respect to the microbiological criteria. For microbiological criteria, you see, earlier the guidelines were, and I'm showing a snapshot from Harrison at the moment, like he said that you had to take 3 samples and these 3 sets had to be sent to the laboratory. The samples had to be taken at a gap of about 1 hour. Like for example, when I'm pricking my patient at 8 a.m., I'll be taking a sample from the left cubital fossa, 20 ml blood, and then I'll put it into separate culture bottles, 10 ml, 10 ml each. Then at 9 a.m., I'll be pricking the patient again, but this time at a different venipuncture site. Like I took a sample at 8 a.m. from the left cubital fossa. Now I'll take a sample from the right cubital fossa. At 10 a.m., I can take a sample from the dorsum of the hand of this person. Why I'm doing that activity is mainly to demonstrate the dissemination of bacteria into systemic circulation, because the vegetation is growing on heart valve, so bacteria is being pumped into circulation. So how we used to teach our students was this 3-to-1, and this 3-to-1 is what I would just like to underline in the textbook snapshot as well. That's going to be 3 2-bottle culture sets. 3 is the total samples that you've taken at 8 a.m., 9 a.m., 10 a.m. And these are every time you are using 2 culture bottles. So 3 2 culture bottle sets which are taken from different venipuncture sites at a gap of about 1 to 2 hours. So instead of 8 a.m., like it could be 8 a.m., 10 a.m., 12 a.m., that doesn't matter. But the main point was that this data that is mentioned is according to Harrison, that is 3 samples or 2 bottles each at a gap of 1 to 2 hours. Now what he's saying is that the updated criteria, microorganism is causing infective endocarditis, has been isolated from a blood culture. It depends upon whether it is a typical organism or a atypical or non-typical organism. If he says it's a typical microorganism that causes infective endocarditis, typical would be like Staph aureus or let me say Streptococcus viridans, then you don't need 3 separate blood cultures to be taken. He says even if you are going ahead, if only 2 or more than 2 separate blood cultures are turning out to be positive, it would be sufficient for diagnosis of this condition. And when I'm taking these separate blood cultures, 10 ml, 10 ml, then one 10 ml would be in an aerobic bottle and the second one would be placed in an anaerobic bottle. Because see, anaerobic bacteria can also, like, streptococcus anaerobic bhi to hote hain. I mean, we have streptococcus viridans which are aerobic, but then we have anaerobic streptococci also. So he says that when you are taking the sample, you should be placing like 10 ml blood in aerobic bottle, 10 ml blood in anaerobic bottle. And now the updated guidelines are that for a typical organism, the commonly seen organism, it is two separate blood cultures which are sufficient. And this was the question one liner in FMG exam, that currently for a typical organism causing, I mean, this was a standard one liner, typical organism causing infective endocarditis, blood cultures positive should be, options were like 1, 2, like that. It is two separate blood cultures that are sufficient. However, if it's gonna be with respect to non-typical organism would be like less commonly seen or rarely seen or occasionally seen. Then with respect to non-typical, it is obviously the standard data of at least 3 separate blood cultures that must demonstrate the presence of this organism. So I repeat the guidelines once again from the microbiological perspective. And the first statement that I say is a must know, that instead of 3, at least 3 2 bottle culture sets, at a 1 hour gap, one, they have removed the time guidelines. Now there is no restriction with respect to that. If the first sample is taken at 8 a.m., second should be taken at 9 a.m. only. He says you can take both these samples, both of these samples that I'm talking about, you could be taking them at the same time. And it is on the discretion of a doctor and cooperation of a patient that ideally you should take it from two separate sites. Like if I'm taking sample 1 from left cubital fossa, I should take the second one from the second cubital fossa, the right cubital fossa. But if a patient is not cooperative, if he's not agreeing to it, or maybe if it's a difficult to, because he's already admitted in a hospital, lot of thrombophlebitis, he says even if you wanna take the requisite amount of blood from a single site itself, it is more than sufficient. Guys, this is again revolutionary, groundbreaking, that the requirements for timing and separate venipuncture sites for blood culture have been removed. So, I mean, this is a gross change. The data on the top is the snapshot from Harrison 21st. I'll just write S21 to say this is Harrison 21 snapshot, which mentions about this 3 to 1 aspect that I mentioned, 3 sets or 2 bottles each at a gap of 1 to 2 hours. But then the updated one for typical organism is only 2 positive blood cultures, and that 2 positivity is, though I have written separate blood culture, is mentioned that categorically in the book, as well as, I mean, the updated guidelines is mentioned that at least, I mean, if it is not possible to take 2 separate blood cultures, so you could be doing it in a single venipuncture as well. So the requirements for timing and separate venipuncture have been dramatically removed. Let us now revise a bit of microbiology, and here we'll just revise the common typical infective endocarditis organisms. So obviously the data would incorporate streptococcus, and even not only streptococcus viridans can be contributing to infective endocarditis, but it can even be anaerobic streptococci, which is why I was teaching you that when we are taking a blood sample, both aerobic and anaerobic culture bottles would be utilized. Now he can make an all except MCQ where even anaerobic streptococci are a part of the flora that can contribute, but he'll say which is unlikely to be contributing to the development or damage to the heart valve. Then this organism has mainly tropism for lungs. It can cause even bacterial meningitis, but does not usually cause infective endocarditis. So 2 of them, I mean, Streptococcus pneumoniae, the leading cause of community acquired pneumonia, and Streptococcus pyogenes, which can cause skin infection, which can cause pyoderma, do not have tropism for damage to the lung tissue. And apart from streptococci, other bacteria that must be taken into consideration would be like group D streptococcus. The correct name for group D streptococcus would be like Enterococcus faecalis. And in case of infection with these organisms, I mean, the aggression that we need to show with respect to antibiotics has to be increased proportionately, because these are fairly destructive organisms. Then you can mention a name of couple of bacteria which are called as typical infective endocarditis organisms, but people do not read about the names carefully. So it is Granulocartella. Then after Granulocartella, the next one would be A. biotropa. Then the third one is Gemella. So a bit of tongue twisting names. Let's do a recap here. It can be written as anaerobic streptococci, Enterococcus faecalis, Granulocartella, A. biotropa, Gemella. Then is, this name for coagulase negative staphylococcus. I mean, we always read the word cons, and what he's going to write in the MCQs, the word staphylococcus lug dunacis. This would not be lung. It is not LUNG. It is lug, LUG, dunacis. That's an alternative name for coagulase negative staphylococcus. I'll just expand the list a little bacteria of this typical bacteria a little more extensive. So this can be incorporating organisms like Corynebacterium. Traditionally, we read about obviously Corynebacterium diphtheriae, but at the moment I'm talking about Corynebacterium striatum. Then another organism that we read can cause pink diaper syndrome in babies, that is Serratia macerans. Leading cause of I can say recurrent pneumonia and cystic fibrosis patients, Pseudomonas, can also cause substantial amount of damage to the heart. And then NTM would mean non-tuberculosis mycobacteria. NTM is non-tuberculosis mycobacteria. And then we could be having fungal endocarditis also, that is with respect to Candida. You see, what you're noticing at the moment is that I've just expanded your vocabulary with respect to typical infective endocarditis organisms by mentioning a couple of atypical names at this particular point of time. So all these are included in this list, and were initially, lots of time they were never picked up. Now they are being picked up, not because the blood culture technique has become more accurate, the blood culture sensitivity is going to remain the same, but because we are using additional investigation, so that is why the ability to isolate these organisms would be relatively better. And once you remember this, then I would also like to add up that apart from this list of organisms that I mentioned, which can be picked up on blood culture, and additional techniques or additional methodologies, let's also make a list of those. What are those tests which are available, and which organisms, or when are these techniques much more beneficial? Then these techniques like PCR or amplicon or metagenomic sequencing would be relatively more sequencing or more, I would say, of importance with respect to three bacteria. The name of the bacteria I had said a little earlier as well. These are non-typical organisms like Bartonella. Traditionally, we read about Bartonella henselae, cat scratch disease, and Bartonella quintana, that is for bacillary angiomatosis. The lesions of bacillary angiomatosis might resemble that of Kaposi sarcoma in a AIDS positive patient. So the same Bartonella that we read as a causative agent for cat scratch and then even for bacillary angiomatosis. Another organism to be taken into consideration is Coxiella burnetii. For Coxiella burnetii, you see, the exception is that even one culture is sufficient. Though I've not written it here, that's in the main video with respect to infective endocarditis. Coxiella or Q fever is a old NEET PG question, because earlier I told you, now I told you updated criteria is at least two cultures to be positive. But for Coxiella, it is one culture positive, or we can use a PCR or amplicon. And the third organism would be the one which I had said verbally earlier, and I'm repeating again. This organism causes malabsorption syndrome. It causes Whipple's disease. So the name of the bacteria is Trophairma whippleyi. It looks like a fungus, but it's not actually a fungus. It's a bacteria. It's a intracellular bacteria which would be hiding in the macrophages of the gut and can involve the heart as well, contributing to development of infective endocarditis. So he says PCR, amplicon, metagenomic sequencing. I mean, more the merrier. I mean, if you are ready to splurge money with respect to diagnostics, you would be able to isolate more organisms which could be present on the heart valves. And nowadays, you see, not only are we having a equivalent incidence of native valve endocarditis and prosthetic valve endocarditis, but because we are putting pacemakers in our patient, because we are putting implantable cardioverter defibrillator in the patient, so the wire with respect to the pacemaker or the wire with respect to implantable cardioverter defibrillator can get infected as well. You see, I mean, where would Coxiella come from? Coxiella would be coming from, like, it's a zoonotic infection. People in India would be keeping sheep in the house or goat in the house or cattle in the house. So a person of rheumatic fever, pre-existing heart disease, has currently from the pet animal in the house got this infection, and because the culture will not be usually positive, so I can be using a PCR technique, or instead of that, there's another way. We can be using indirect fluorescent antibody, IFA. And with this indirect fluorescent antibody, we can be demonstrating presence of IgM class of antibody and then immunoglobulin G class of antibody, again for organism like Bartonella. So you can see that I've just expanded the information here with respect to which bacteria, the non-typical ones, are the ones where these techniques would be highly, I mean, you can do PCR for everything, but then, to be able to isolate Trophairma whippleyi routinely on a culture would be like, looking for a needle in a haystack. So that is where these techniques would come much more handy. And I've deliberately spent more time on the microbiological criteria because that is the only thing that is asked. Especially if you are an FMG student, what you need to remember or listen to in this video next is only the summary of the microbiological criteria that I mentioned. And even if you don't listen to the remaining subsequent data, it would be more than sufficient for you. Or obviously, if you're sitting for NEET PG or if you're sitting for more competitive exams, you need to listen to the subsequent data. You learned today that for typical microorganisms, at least two cultures have to be taken, and these two separate cultures, ideally, he says this fact that the best practices are that you would be taking blood sample from different sites, but there is no timing required at the moment. So he says at least two separate blood cultures turning out to be positive, and you are sending the sample in both aerobic and anaerobic bottles. So it's a 20 ml draw every time. For non-typical organisms like the ones that I mentioned, it is three separate blood culture, or we are having PCR for BCT. What is BCT? Written right on the top, but we just practice it once again. That would be Bartonella Hensley, or Bartonella quintana. Then would be C would be for Coxiella, that is Q fever. And then T would be for Trophairma vipili, the same organism that causes malabsorption syndrome. And then is indirect fluorescent antibody that is mentioned. Antibody titers are also described for this one. That would be again for Bartonella. So the main message is if you can get this much of information right, I have just summarized this information and I'm saying, okay, this is all that is required for you. It looks very simple, but people tend to mess up between these informations that are provided, especially when he says multiple correct, then yep, I mean errors of judgment tend to occur and people tend to neglect this data. And in the subsequent slide, I'm going to focus on the imaging perspective, and I'll also focus on the reasons why, why is he talking about using additional imaging methodologies. Now, as I've explained to you, that if he just says that what is the first line investigation to be done for any suspected infective endocarditis, it is echocardiography. I'll use a different color to highlight this. You see, on a comparison basis, transesophageal echocardiography will be having a higher sensitivity as compared to transthoracic echocardiography. He says if both are available, great, but on a sensitivity comparison, transesophageal echocardiography is superior as compared to transthoracic echocardiography with respect to a question that says, what is the first line investigation? Imaging perspective, first line imaging investigation that should be done in any case of suspected endocarditis. And he may not mention IV drug user, or he may not mention that he's having a cardiomyopathy or any congenital heart disease, or patients undergone any kind of surgery. Like those traditional risk factors are obviously present, and most of the time infective endocarditis occurs in the setting of this information. But even if a person has previously had an episode of infective endocarditis, then he can have a second episode as well. So the message is that first line imaging modality for any suspected infective endocarditis in a person who's had an infective endocarditis earlier is transesophageal echocardiography. Just because he's saying that he earlier had infective endocarditis, don't start answering hi-fi investigations like PET-CT or cardiac CT. Previous episode, IV drug use are standard risk factors. Your answer is still an echocardiography. The main advantage of a cardiac CT imaging is, as I explained, that you are able to pick up those paravalvular lesions. Now, what are those paravalvular lesions that we encounter most of the time? Well, one of the important paravalvular lesion could be a creation of a fistula. The organism is causing local damage, so it could contribute to connection between two chambers of the heart, or it can result in development of a valve abscess or a ring abscess. So because I'm worried about these dangerous complications, that is why cardiac CT is being discussed. And over and above this, as I've said, we can be using 18F FDG, that F would be for fluorine, this is fluorodeoxyglucose. PET-CT. Traditionally, we use a PET-CT for demonstration of distant metastasis, but he says that a PET-CT is always going to be better. What is the rationale for using a PET-CT is that echocardiography and cardiac CT are like very, very good for native valve and paravalvular area. But if it is prosthetic valve, better detection rate with respect to PVE, that is prosthetic valve endocarditis. In prosthetic valve endocarditis on echocardiography, they can be a development of dehiscence. I'll just write it, but better detection of prosthetic valve endocarditis. Or if a patient is having a cardiac implantable electronic device, like I said, somebody is having a pacemaker, the wire of the pacemaker can become infected. The wire of the implantable cardioverter defibrillator can become infected. So CIID would mean that there is a cardiac device, it's implantable electronic device, cardiac implantable electronic device getting infected. So that's like a pacemaker or ICD. So if you want to pick up the newer devices that are put or artificial heart valve has been put, like let me say this patient had valvular aortic stenosis. He developed prosthetic valve endocarditis. The aortic valve got infected. So a PET CT would be able to pick up, abnormal metabolic activity, and thereby giving earlier diagnosis as compared to, I don't want to wait for a perforation to develop in a heart valve and or a abscess to develop in a heart valve, and then I should say that okay, I'm giving you a shattering diagnosis that you're having infective endocarditis. Why to let the patient suffer? So he says if there's an abnormal metabolic activity, usually, this abnormal activity from the major criteria should be remembered as after 3 months of any cardiac surgery. Do remember this statement, because if I'll make it, this PET CT will come in minor criteria also, and there I'll be saying the word abnormal metabolic activity detected within the first 3 months of cardiac surgery. If it is within the first 3 months of cardiac surgery, we take it as minor criteria, and if it is after 3 months of cardiac surgery, we'll take it as a major diagnostic criteria. So at the moment, I've given rationale behind a cardiac CT and a PET CT. In simple English, it's like this: cardiac CT very good for paravalvular. But if it is prosthetic valve endocarditis, traditionally echocardiography report with respect to prosthetic valve endocarditis will say dehiscence of the valve. But then the point is that tear or the dehiscence of the valve, the whole architecture is getting destroyed. Why should I wait for that architectural distortion to occur to be picked up on an echo? Before this distortion or dehiscence occurs, I can pick it up on the basis of a PET CT. So that's the beauty of a PET CT, early identification with respect to specifically prosthetic valve endocarditis or the wires which are with respect to these interventional cardiology devices like pacemaker or implantable cardioverter defibrillator is the reason, why they can be the infection of these can be picked up earlier is the rationale behind usage of a PET CT. Lastly, the surgical major criteria is what I've already mentioned, that a cardiac thoracic surgeon would be doing a direct inspection of the heart valve, and if there is demonstration of damage present, well, let it be. This is sufficient for diagnosis of it. What I mean by let it be is that it is sufficient for diagnosis of infective endocarditis even in the absence of any imaging evidence or absence of any microbiological confirmation. Then our changes with respect to the minor criteria. Till now I've told you updates with respect to SIM, the surgical major criteria, imaging criteria, and the microbiological criteria. Now we'll focus on specific information with respect to the minor ones. One is with respect to predisposition. What I mean by predisposition is a person can be an IV drug user, he can be having a structural heart disease, he could be having cardiomyopathy. Any patient with structural heart disease, rheumatic heart disease, if there is a pre-existing damage, then it is sufficient, to be taken as a minor criteria. But now over and above this, he says if somebody is having previous history of infective endocarditis, though I said it earlier, I'm saying it again, that previous history of infective endocarditis is a minor criteria. When did I say previous history of infective endocarditis? I was talking about a patient who's had a first episode and now is having another episode subsequently. So I can do an echocardiography. But if he's mentioning himself that imaging, the person had an episode earlier and now is being subjected to an echocardiography, that means that both major and minor criteria are positive in a patient. The major criteria is the echo that he's gonna mention the report of. And because he's mentioned the previous history of infective endocarditis, you will take it as again a point for minor criteria. In FMJ exam, no, they just gave a 3-liner question. This was, I think 2023 again, the first paper that occurred, where they gave a 3-liner, 4-liner question, and it was full description. Known case of rheumatic heart disease, fever with chills and rigors, and previous history of infective endocarditis. So you had to calculate, how many minor criteria. The question mentioned how many minor criteria are present. Options were like 0, 1, 2, 3. You will find that question in the PYQ section. Or if you want to go for the explanation, obviously the YouTube channel is there. But the main point is previous history of infective endocarditis was not present for previous 23 years and has been added at the moment. And similarly, he has also added an additional information that would be that a person is having a presence of a cardiac implantable electronic device. I mean, that CIED terminology is again a predisposition. Just like cardiomyopathy is a predisposition, hypertrophic cardiomyopathy, whether it can be congenital heart disease. A patient might have undergone a surgical operation for the same, but again, when you fiddle around with the heart and there has been a surgery done on the heart, the chances of infective endocarditis tends to increase. Then in the vascular phenomenon, now they have included presence of a cerebral abscess as well as a splenic abscess. Now this will be a very mood upsetting data for you guys, because in the main section of infective endocarditis, I have told that cerebral abscess or a splenic abscess is a complication of the disease and it is not a part of diagnostic criteria. I repeat my statement, guys. According to 21st edition of Harrison, splenic abscess and cerebral abscess are not a part of diagnostic criteria, but they are described as complications. The query in your mind would be, what should we answer in the exam? So if the MCQ simply says modified Duke's criteria, answer on the basis of Harrison, that's the subsequent video that you still have to watch, because I'm teaching you the update. But if he himself says 2023 updated criteria, then both of them, cerebral and splenic abscess, are going to be taken as a part of minor criteria. Then PCR or amplicon can help in diagnosis of infective endocarditis from the perspective of minor criteria as well. Why PCR is both a part of major as well as a minor criteria is that, suppose of the fact that I'm able to demonstrate a typical pathogen. The names of the typical pathogens I've already explained to you on the previous slide. But if I'm able to demonstrate a typical pathogen on the wire of a CIED, that is a cardiac implantable electronic device, that is sufficient to be taken as 1 point in favor of minor criteria. And then we need to use the algorithm, which is either 2 major criteria or 1 major with 3 minor or 5 minor criteria. I'm not writing that down, and I would not even suggest the notes people to note it down, to give it in a printed format to you guys, because this is discussed in the subsequent part of the video. Then is PET-CT. Now, query of yours would be, sir, you just told PET-CT for major criteria, then why are you including it in the minor criteria? Why has these authorities included it? They put up a rider here that, PET-CT can pick up early issues with respect to infective endocarditis. Like, patient underwent a cardiac surgery, and within 3 months of cardiac surgery, if PET-CT is showing a abnormal activity, then I'll say it is a minor criteria. And if the PET-CT is showing it after 3 months of cardiac surgery, we'll take it to be a major criteria. So do remember that rider that I mentioned at the moment. And then they have added this word or this statement, which will again be a very mood upsetting data for you, because if you check out in the 21st edition of Harrison, he has mentioned this line as, I know at this moment this is gonna be a little upsetting, or it's gonna upset, not upsetting in a sense that it will upset your mood, it will upset your rhythm, guys, because these two statements that I'm mentioning are in stark contrast to what Harrison is saying. Harrison is mentioning that if there is a new onset murmur, if you are doing auscultation of a new onset murmur, it means, because new onset murmur, why will it occur? Because there will be a perforation in the valve leaflet. If there's like infection with respect to aortic valve, then the bacteria will damage the tissue of the aortic valve, and there would be a perforation created, which will cause leakage of aortic blood back into the chamber of the ventricle. It's not that the valve approximation is defected, but there's a hole in the valve leaflet which is created due to the destructive process created by the bacteria. So new onset murmur in a patient with pre-existing heart damage was taken to be, is written in the major criteria part in the 21st edition of Harrison. But look at where I'm writing it. New onset murmur is being mentioned with respect to minor criteria. So how are you going to answer in the exam? If updated is given, follow what I'm saying at the moment. The data is new onset of regurgitation murmur. Well, the reason for this regurgitation is that the blood will be leaking from higher pressure chamber. It could be leaking from either LV to LA, or it could be leaking from aorta into the left ventricle. So new onset of regurgitation murmur should be remembered as a minor updated Duke's criteria. They have change these data on the basis of prevalence. I mean, most people, when they give me a feedback, they say, sir, how do you expect us to remember so many things? So at this moment, all I can say is that till the next edition of Harrison comes, we have to remember both the informations. This is just identical to like in hypertension. In hypertension, the cutoffs are like the GNC 8 criteria was 140/90, and then the AHA guidelines are 130 onwards only. So, and then even in diabetes mellitus topic, In diabetic ketoacidosis in pediatrics, they have removed the dose of bolus insulin. That bolus insulin is given in Harrison for adult patient diabetic ketoacidosis, but the pediatric one is changed. So, I mean, these updates, when we listen to them the first time, they tend to upset our rhythm a bit with respect to ability to recall the information, because there are two sets of data which are to be remembered. But I think that if you just make a practice in your handwritten notes with respect to the minor criteria that I have mentioned at the moment, and especially the minor ones, which will be a long stem question, I will say select the minor criteria based on the updated ones. And this data, a lot of guys are possibly may not pick up, or might answer that as a major one based on the Harrison based data. So I think I've given you enough sensitization with respect to the updates, and I think then when you correlate this information with the main video of infective endocarditis, you would be good to go with respect to solving these questions in the actual real scenario. So keep the pressure on, keep hammering, and I know you're gonna do great in your careers.